Hey everyone! This presentation will cover cognitive approaches to debiasing, made by Philip Lamb, Alyssa Macfarlane, and Sharon Tang.
Biases, both implicit and explicit, exert a great influence over our decisions. Let's focus our attention on individuals in positions of power, such as healthcare professionals, law enforcement officers, and employers, to name a few. Doctors may generalize and associate details of one patient's case to another and make false diagnoses. Police officers' vigilance in assessing danger can be influenced by their implicit race biases. Employers with gender bias often pass on suitable female candidates for less qualified males. When the decisions of an individual directly affect the lives of other people, their implicit and explicit biases must be identified and checked to avoid detrimental effects on society.
Being biased is part of what makes us human. Though we may not always be able to control them, being aware of our biases is a crucial first step needed to make a change. And this is where debiasing comes into play. It first began in the 1980s when a researcher by the name of Fishoff used cognitive trainings to teach people how to understand different types of biases, where they originated from, and how it affected their judgment. Fishoff offered different strategies to mitigate the effects of these biases. These early cognitive trainings had minimal success, but modern approaches have yielded better results.
Cognitive debiasing involves changes that rarely come about through a discrete single event, but instead through a succession of changes, from awareness of the bias to deciding to change, then initiating strategies to accomplish change, and finally maintaining the change. In everyday life, bias is found in decision-making, which is a complex system that can be understood as a dual process, Type 1 and Type 2. Type 1 processing is fast, implicit, and intuitive. Type 2 is slower, explicit, and logical. The neurobiology behind making decisions is very complex, involving multiple mechanisms that are not completely known, but Type 1 intuition is suspected to be linked to the left temporal lobe system and the ventromedial prefrontal cortex. Type 2 logical reasoning is thought to involve a bilateral parietal system as well as the lateral and dorsal prefrontal cortex. The theoretical basis of cognitive debiasing is switching from Type 1 to Type 2 processing. With this understanding, several studies have attempted to debias healthcare professionals. Research suggests that diagnostic errors are more commonly a result of flaws in clinical reasoning, not a lack of knowledge. Misdiagnosis can be attributed to different biases, like anchoring bias or confirmation bias. A 2015 study by Smith and Slack found that giving educational workshops to medical residents to recognize bias and avoid misdiagnosis was ineffective. The debiasing training involved informing participants of various types of cognitive bias and practicing reflective exercises. Even after forming their own strategies to minimize bias, the physicians did not seem better able to recognize their risk for cognitive bias in follow-up clinic visits. These results suggest that cognitively being taught to recognize bias is not enough to help our brains use Type 2 logical reasoning. While this study failed to debias, it's not quite that simple. A 2017 review of research in debiasing health professionals found that about half of published studies on cognitive debiasing were successful. While the neurology behind these cognitive debiasing strategies is not yet understood, debiasing medical professionals has great potential to benefit patients. Interventions and trainings could improve the accuracy of medical diagnoses and prevent further injury or death resulting from misdiagnosis.
In this research paper from 2016, med students were given a mnemonic, TWED, to facilitate metacognition and make a correct clinical diagnosis. And this is important because a patient has so much to lose when there is a wrong diagnosis. A diagnostic error can occur from something such as overconfidence bias, in which the med student is more confident in their abilities than what is objectively reasonable. And this is associated with increased activity in the striatum, which is a brain area involved in reward processing. So, metacognition is a way to evaluate and control our own cognitive thought processing. In this case, it urges med students to reason through a patient's case and compare and contrast their initial diagnosis with other alternatives. Referring back to the dual process theory, this serves to facilitate a type 2 cognitive thought processing. And the cognitive neuroscience of metacognition involves the prefrontal cortex, which plays a role in decision making. During decision making, studies have shown that there are neuronal interactions between the dorsolateral and ventromedial prefrontal cortex. The TWED checklist is designed to reduce cognitive bias and assist the med student in making better clinical decisions. So T means threat. Does this person have any life-threatening conditions? W stands for wrong. What if I'm wrong? Like, what else could it be? E for evidence. Is there enough evidence available to prove or disprove a diagnosis? And D stands for dispositional factors. What other factors could be affecting my decision making? Am I sleepy or tired, or maybe my working environment is super chaotic?
40 final year med students from Malaysia participated in this study. The 19 students in the control group received a 90-minute tutorial on electrocardiography, whereas the other 21 med students received a 90-minute educational intervention. This video addressed various cognitive biases and covered debiasing strategies such as the TWED checklist. In addition, the video also gave examples on how to apply the TWED checklist in clinical cases. So 2 weeks later, the med students from both groups were instructed to complete a test consisting of 5 different clinical case scenarios. So here's a picture of one of the scenarios on the test. These scenarios were purposely framed to cause the med students to make an obvious diagnosis that was incorrect. This was done to encourage the med students to explore alternative diagnoses. Each case scenario also included common cognitive biases that were covered in the intervention video. The questions at the bottom of each scenario assess their ability to generate alternative diagnoses and also make judgment calls on managing the case for each patient. And the test results at the end showed that the students in the intervention group scored higher in all 5 cases than those in the control group.
Prejudice often manifests as a form of discomfort regarding intergroup contact, particularly when an individual has had minimal encounter experience with an outgroup. As a result, the initial contact becomes an experience characterized by uncertainty and anxiety, which can promote bias. According to Alport's contact hypothesis, positive and regular contact between people from different groups should help with improving judgments of the entire group. Existing evidence demonstrates that intergroup contact has been effective in resolving both affective and cognitive features of prejudice. Interestingly enough, research has shown that simply imagining a particular social context can have the same effect as actually experiencing that context. This imagined contact cognitive training approach is based on mental imagery, defined as the conscious and intentional act of creating a mental representation of a person, object, or event by seeing it with the mind's eye. Mental imagery shares many features with real experience, including concrete details, causal sequences, logical constraints, emotional arousal, and similar neurological characteristics. Evidence suggests that subtle cues in our social environment prime or activate associated knowledge networks in our minds. Mental imagery increases the accessibility of related cognitive, emotional, and behavioral representations, leading them to have a strong influence on our attitudes and behaviors. The imagined intergroup contact hypothesis by Richard Crisp and Rhiannon Turner is an indirect contact strategy which seeks to promote tolerance and positive intergroup relations. This technique encourages people to mentally simulate positive interactions with outgroup members with the aim of reducing prejudice. One particular study, conducted by Turner and his colleagues, studied the effect of imagined contact on the attitudes of heterosexual men towards homosexual men. Participants were told to imagine talking to a gay man on the train. Following the imagined scenario, participants were asked a series of questions which assessed the presence of intergroup anxiety, outgroup evaluation, and perceived outgroup variability. The results of the study showed that after imagined intergroup contact, participants had improved attitudes, judgments, and reduced stereotype generalizations regarding the outgroup gay man compared to control group participants who were just told to imagine being outside. The premise behind this training approach is that mentally simulating a positive contact experience activates concepts that you would normally associate with real interactions, such as feeling more comfortable or less apprehensive about the idea of future contact. By increasing the accessibility of these associations, mental imagery can be used to moderate implicit processes such as stereotypes and other forms of bias. Although imagined contact may have a weaker effect than real experiences, it does not require any direct contact, and so its practicality and accessibility make it an ideal intervention tool for prejudice-reducing efforts. With further research, imagined contact can be developed to improve workplace trainings and anti-discriminatory policies aimed at securing and promoting diversity.
As a whole, a lot is still unknown about cognitive debiasing. Results are mixed, and the neurobiology is unclear. However, with additional research, debiasing could provide new opportunities for collaboration, facilitate effective communication, and even save the lives of patients.